Hi,
Hi,
Miriam.
Judy. How are you?
I'm great. How are you?
Good. So good to see you.
Yes, good to see you as well.
That's what I
And
wanted to start focusing on with these webinars. We wanted to kind of like make a short introductory webinar so we can feature a special dentist like you, and then get your input on how important it is to take care of airway and TMD at this point. Wanted to introduce you, and hopefully, through social media, I don't know if you've seen, we've been very active through social media,
yeah,
bringing awareness that way. We want to feature our doctors who are trained, and that's why I asked for this meeting with you today. Wanted to introduce you. In my book, you're under a superwoman because
oh,
of
you're
who
too
you
see.
are.
See, I think that should be reversed. Under my book, you're under like major superwoman. I always talk to my girls about it. I'm like, yeah, Dr. Malak, she is just amazing. She,
Oh, you're
she
so
started this Myoaligner company. They're wowed by what you've accomplished.
Thank you. Well, look at yourself. You're not only a full-time mom, and but in the 8 years that you graduated from dental school, you got your fellowship from Academy of General Dentistry, and you also received your fellowship from International College of Craniomandibular Orthopedics, which is very impressive, because we know there are a special group of dentists that go beyond just the mechanics of dentistry and tooth dentistry to more of becoming experts in craniofacial development and oromyofunctional therapy, and you just see. I'm sure you see a patient very different than a general dentist.
Yes.
And I wanted you to kind of like today focus on that and tell me how is it that your training has made you come bring you here, and why is it that patients are asking for your treatment and expertise so much compared to a general dentist. So tell me a little bit about your background, your training, and how you became a neuromuscular dentist, and now airway focused through VIVOS. Yeah.
It started with really my own journey through dental school. I had probably at least 15 migraine headaches a month, was never headache free, constant jaw pain. And so I had grown up, my own mother had a very similar story, but she had been a 40-year migraine sufferer. So
40
uh,
years.
40 years, yep.
Wow.
So she had just said, well, this is your life. I'm really sorry. Everyone's been, has told me my whole life, no one can help you. So suck it up. And that's what I did. So through dental school, I would wake up at 3, 4 a.m. just to assess my pain level and give myself, either a shot of sumatriptan or take a pill, or I would assess where I was at to know how to make it through the day. And that's how I made it through dental school. So going into practice, I just figured that was my life. And my partner was really wonderful in convincing me right out of school to get trained to do ortho. They had a really busy general dental practice, and we live in a smaller town, about 10,000 people. So he had said that a lot of the patients prefer to stay in town to do ortho treatment, and he wanted to get me trained. So he had suggested I attend training through Jay Gerber, which was wonderful.
Oh,
And right away, Jay diagnosed that that I was in pain. He probably first class, he looked at me and during a break, he said, all right, we need to help you. So Dr. Gerber treated me, and immediately my migraines went away. And that's when I knew that this was what I needed to do. So
what is it that he looked at differently than most orthodontists that you met through dental school and through your life? What is it that was different?
So instead of looking at the teeth, we looked at the joint. A very different approach. I had been through orthodontic treatment as a child, and instead of making room for the teeth, we extracted teeth. Instead of making sure that the joint was in line and the muscles were happy, the upper jaw was pushed back, was retracted, and that is what set my course of pain from there
So
on forward.
you had a headgear
I
to
did.
stop growth of the upper jaw because of the crowding. Teeth were
Yep.
extracted, and your bottom jaw was
Was
retracted to
then
match
retracted.
that new position. And that's
It
what
was.
put a lot of strain on your head muscles and the joints. So
It was. It
how
was. Yep.
so did you have braces in dental school or as a teenager like most of
Nope.
us?
As a teenager,
Yeah.
probably finished around 16, and that's,
Is
around
that when the
18.
headache started? Yeah.
It is, yep,
Yeah.
yep. So Jay looked at things from a totally different perspective, and we aligned the joint in the right spot and the muscles in the right spot.
Mhm.
And from there on forward, then continued to try to bring the teeth into the right spot. So that's what kind of jump started my interest in this area, is seeing what a dramatic difference it made in my own life, changed my
Yes.
life. I had been hesitant to have children because, I could never predict what kind of pain level I was going to be in, and so, it really changed the course of my outlook on everything. So when I completed ortho training, I then went through Dr. Gerber's mini-residency for TMD, and then everything just snowballed from there, because I started realizing we need to, yes, I can fix joint position, but then how can I make these patients stable? And
Yes.
so that's what then started my journey down, learning about airway, and then learning about myofunctional therapy. I would see some patients that get much better, and other patients that get better, but they still have some tension headaches, or they're still having some issues with airway, even though we're expanding the airway. And then that led me to, okay, let's look at the oral ties. Why do we have the bones develop the way that they're developed, or underdeveloped per se? Well, muscle function. And then that started my journey down looking at treating younger and younger and younger. So, all the way to now I'm assessing infants and talking to pregnant mothers about, let's assess your newborn if you're having trouble with nursing. And so it was just a amazing journey, and still is.
Yes.
Just keep learning, every
It's
year.
amazing because
Yeah.
you can change people's lives. Look how much your life changed.
Mhm.
It's amazing how much we put up with chronic pain and think it's normal. Even you as a doctor having access to best treatments,
Yep.
you put up with it for almost like what 30 years of your life, and
Mhm.
you thought that was normal. Your mom
Mhm.
went through that, and it's amazing. And that's, when I met you at ECMO, I was just so impressed with you, as a woman, as a mother. It's not easy to get all this training,
No,
hours and hours of
it's
continuing
not.
education, swimming against mainstream, because mainstream ortho, orthodontists or dental schools, they don't teach you this perspective. They mainly focus on mechanics of the teeth and one tooth dentistry. And patient dentists like you that look at the whole patient and have a more of a multidisciplinary approach, they completely see the patient different. I totally
Yeah.
understand. We can look at a 5-year-old, and see if they're suffering from airway or not by just
Yeah.
looking at the dark
Yeah.
circles under their eyes, the way their
Yeah.
nose has shaped, the way they're holding their mouth open slightly. And it's amazing when I ask mothers, family or friends that are, when I see their children and I ask about their habits, they're blown away by what I can just say, or what I can tell about their health by just looking at them.
Yeah.
So what is it that you look at a patient, when you get a new patient? What is it? What jumps out at you? What do you look at besides just taking x-rays of their teeth and checking their gums?
When I talk to patients, I always tell them I'm looking at three things. I tell them I'm looking at the teeth very last, but I'm looking at the bone structure. So, the upper jaw, is it wide enough? I'm looking at placement of that upper jaw. Is it too far back in relation to the rest of the face? Is everything in balance? And the lower jaw, what type of placement do we have there? And then I tell them I'm looking at muscles. So not just muscles that open and close the jaw, but the tongue, the lips, the cheeks. Um, is there a restriction there? Are the muscles functioning in balance? And so when I talk to a parent or an adult about what I see for them, I always break it down into those three categories, and I always tell them, the teeth are usually in the position they're in because of those other two things, and the
Mhm.
bones are usually in the position they're in because of the muscles. And when I propose treatment, then I look at saying, okay, let's get all of these things into an ideal situation,
Mhm.
starting with muscles, and then let's catch the bones up if that needs to happen, and then teeth last. Let's support that position. And that's how I go into my evaluation with kiddos and
Okay.
adults.
And adults too.
Yeah, everybody.
So you start by relaxing the muscles because you understand that it's the muscle spasm that's causing the majority of pain, and it's a mandible that has been thrown off its correct, what we call physiologic trajectory or
Yep.
physiologic position. So
Yep.
you probably implement an orthotic, very non-invasive,
Do.
right? First
We
phase
do.
is to relax the muscles, and you tell us a little bit more about how you do the orthotic therapy. You know, is it your phase one to get the patient out of pain, address their
Yep.
TMJ, find the mandible in the right position, and then tell us more about that step, please.
So typically, if we have a patient that's in pain, and this would be most of the time in my practice, it would be anyone, 14, 15 on up. If they come in and they're in pain or they have noises in their joints, what we want to do first is get that joint aligned in the right spot. And you can't ask that patient to, okay, remember this spot and keep coming back to that spot. Before we do any type of expansion or any type of moving of teeth, we have to get our endpoint. And that's what I'll usually talk to our patients is, let's find the endpoint first, which is the joint in the correct position. And so in our practice, what I do is we relax the jaw muscles first. I use ultra low frequency tens to get the jaw muscles nice and relaxed, because the muscles have a memory. So when we ask someone to bite down, they're gonna remember where that placement is, whether that's good, bad, or otherwise. So we want to kind of relax those muscles and kind of confuse that memory per se. And once we have the muscles relaxed with the tensing, then we look at finding the correct position. So in our practice, we take a CT scan, a 3D X-ray, so I know where that joint is to begin with, and then I use K7 computer equipment to help me with figuring out where that jaw is in space, helps me to kind of quantify, okay, I know based on the x-ray I want to move this many millimeters, and so the computer equipment helps me with that tracking, and it also measures the muscle activity, the EMGs, so I'm able to see if indeed I am placing the jaw in the correct position for the muscles. So we come up with a very specific spot, and then from there we create an orthotic for that spot. So many times an orthotic can be confused with a splint, and a splint is just a flat plane. The bite is not calibrated, the jaw can move anywhere. In our practice, we utilize an orthotic, which is worn on the lower teeth. It's at that very calibrated, specific position. I tell patients to kind of think of it like a foot orthotic. You're not going to just go get a Dr. Scholl's insert and guess on where your foot needs to be, if it needs to be aligned or hip needs to be aligned. It's going to be a calibrated position. And so that's what we think of the orthotic. And in our practice, if there's any type of pain to begin with, my patients need to be pain-free for at least 4 months before we move on to building them in that stable position.
That's a great point, because research has shown that it takes about 3 to 4 months for the bioremodeling happen,
Correct.
especially when you're in an anatomical orthotic, a functional orthotic that the patient can wear all the time.
Yes.
So that joint during chewing and function and swallowing, that joint is not beaten up. It's always in the correct position. And some ortho research, back in the 80s has shown that the actual articular eminence and the head of the condyle, even there's some bony remodeling that happens. So I'm glad that you're following the 3 to 4 months, and that's exactly what we do.
Yeah.
That brings me to my next question. So you have placed you have used a few of Myoaligner functional
Correct.
orthotics from our company, and I wanted to know, how was your experience with that? How did it compare to more of a acrylic orthotic, a full arch orthotic? And did you find more compliance with these anatomical invisible orthotics basically in the mouth? What was your experience?
Yeah, I really, really like them. My patients have had great things to say. For years I've been using the acrylic orthotic, and that's a bit bulkier. And the thing that most patients really have a tough time with is the speech issue. So when you add acrylic into the mouth, then you take up space for the tongue has to find and adapt a new spot to be. And in somebody who's already restricted on space, now you're taking up some space behind the lower front teeth. Some people really have trouble with a speech issue, you know, and sometimes, and many times, we have to wait to get that development of the upper jaw and get more space for the tongue. So when you're reducing tongue space, that's a problem. And so patients find that very uncomfortable. The other thing that is uncomfortable, I instruct all of my patients that they need to eat with the orthotic in, because we need that joint position to heal. So you know, it would be like having a splint on your wrist for a broken wrist and then taking it out to, you know, taking it off to write. You can't do that.
No.
You know, so eating with a traditional orthotic, a lot of stuff gets stuck underneath it, and they really don't like that. So with the Myoaligner and a topical orthotics, I've had a few patients where they've had the traditional orthotic first, and then we've moved to a Myoaligner because I just wanted to get some feedback from them on what they think. And a couple of the patients had an orthotic for many years. They had decided that they didn't want to do any additional treatment, and they just wanted to have an orthotic in their mouth until they got to the point where they could save up and do orthodontic treatment. And so one particular patient, I said, you know, let's try the Myoaligner, see what you think. And she just raved about it. That she said the speaking was just effortless. She said it felt very much like having natural teeth again. She almost had tears in her eyes. And she said the eating aspect was wonderful. So I ordered one actually for my own mother, who has been in treatment for years, and same thing. She loves it. So yeah. So I started with many of my younger patients. I started moving towards ordering the Myoaligner segmented orthotic for the start of those patients. So many of them haven't been able to, you know, haven't had the experience of having the acrylic orthotic. We have just placed the Myoaligner as our first device, and I haven't had any issues with it.
That's what I've been doing for the past 3 years, since 2017, that I developed the concept of segmented orthotic. Every patient gets a Myoaligner, and you know, that has helped me from transitioning to a full arch acrylic to a fixed orthotic, you know, to the next step. I'm just eliminating a lot of steps, which reduces the cost for the patient too. Another main aspect, which is the main focus of my research for ICMO, is the segmentation feature. Because when I talk to gurus like Ira Shapira, you know, he reminded me of research that was done in the mid-80s on implants. You know, he says that's why we don't put a bridge from 18 to 31, because of the flexion of the mandible and flexion of the cranial bones that goes on. I know, and with orthotropics and epigenetic orthodontics, we know that these bones are always flexing and remodeling. So, you know, I think one of the reasons that Myoaligner is more comfortable for patients compared to a full arch orthotic is because it allows for that little bit of a flexion of the mandible, and it doesn't cause any extra temporalis tendonitis. And, you know, gurus like Ira Shapiro said they used to just cut their orthotics in half, you know, and they would see an actual separation or 2 millimeters of gap opening, because that mandible was not stuck in that position and you can relax.
So that's interesting that you say that, because that was going to be my next comment. Is I utilize, once we're pain free, I utilize a lot of upper DNA appliances, and I have found that there's always that transition period when, you know, we insert the DNA appliance, but we still have to have support for that bite position on the lower jaw. And so, and so having the segmented orthotic has been really great, because I feel like as the cranial bones start to change and start to even out, I have much less adjusting with the Myoaligner device rather than the traditional acrylic orthotic, because those lower bones are able to flex and change too. And so it's been, on my part, much less chair time, and the insert is much less chair time. I've had virtually no adjustments on insert. With the acrylic orthotics, there's usually quite a bit of adjusting on the occlusal. So that part has also been really, really wonderful. It just,
Well, we're down to 5
printed.
micron accuracy with digital
It's
design and
amazing.
digital fabrication. You know, there's no hand articulating or anything like that. So, and the technology is there. So we're excited. You're absolutely right. And the chair time is so valuable. I used to do a lot of fixed orthotics for my full mouth reconstruction cases. That took me about 3 hours to deliver the fixed orthotic with the stand, especially if it was tall, cleaning up all the excess around the linguals, fine tuning, because you can press harder on one side than the other when you're just delivering it. Now with a Myoaligner, it takes me 10 minutes, not just me, other doctors from ICMO that have tried it, they're like, oh, it took me only 10-15 minutes to deliver a fixed orthotic, and I didn't have to adjust anything because it's all computer designed. So I'm really excited that people are. One of the cases, since you brought up DNA, one of VIVOS instructors who's actually gone quite a bit of expansion. She had 40 years ago, she had bicuspid extractions for bicuspid extraction that put her in severe sleep apnea. So 2 years in VIVOS appliances, she has opened up almost the space for the bicuspids, and she had that bicuspid drop off that's mostly showing on the top. So just this last weekend, we put 2 Myoaligners on top. That really aesthetically just gave her that arch, replaced the bicuspids, and she's not done expanding, even though her HI is down to 5 now from 30. She wants
That's
to expand
wonderful.
a little bit more. And so that just gives us the option, because Myoaligner is segmented, give us the option to just keep expanding, maintain her physiologic bite during the day, and then continue on. Another case we had was with a crossbite. When you're having a crossbite, bilateral crossbite, and you're trying to expand at night, during the day, if they just bite on that, the bottom teeth are just going to bang those teeth in. So with those, we design Myoaligners that are kind of like flatter on the buccal cusps, so patients can wear that during the day and at night, expand during the day, and not reverse that expansion during the day with the flat cusps. And you can do
that's wonderful.
on the Myoaligner instead of grinding the buccal cusp of the teeth. So it's been helping us that way a lot too.
Yeah, there's so many uses. It really has opened up quite a few doors in my practice as far as options for my patients, and treatment time is starting to decrease a bit, which is great. Like you said, instead of having all of those steps for the patients, we're able to start out with an anatomical orthotic from the beginning and allow those cranial bones to do what they need to do. And I feel like it really is decreasing treatment time in our practice, which is great.
That's great. So once you stabilize these patients in an orthotic, then after 4 months, you said you'll go ahead and just have a consult with them, right?
Yep.
And if they can graduate to phase 2 and make this more into a more now that they've gone through test driving a new bite, they're comfortable, you have gained their gained their faith, in you that you can actually help them. Then you probably go to phase 2 and start expanding the upper jaw, right? Opening up the airway. I always tell my patients, especially during this pandemic, and people are protecting themselves with a mask. I tell them you have the best HEPA filter built in right here in your nose.
Yes.
And not only that, the nose is the only body part that releases nitric oxide gas, which constantly disinfects the virus, and there was some research done in 2005 that it actually killed 97.8% of H1N1, nitric oxide. They didn't do it, in the nose, but the nitric oxide. So I just tell my patients, the biggest asset you have is to be able to keep your mouth closed and breathe through your nose, because that nose will probably filter all kinds of viruses for you.
You are absolutely correct. Yes.
Yeah. So, and that's what you're trying to establish for your patients. And so I really appreciate your time, and if you have any message to our patients, patients that are listening to this, with your permission, we'll go ahead and share this with, with people that are our followers, so they can learn and even if they're in
Perfect.
your area, they'll contact you for help.
That sounds great. Thank you for everything you're doing to get the word out and help patients to find the correct treatment to get them feeling better.
Thank
Really
you.
important.
Thank you, Dr. Stafford. Have a great
Yeah.
day.
Yes, you too.
Thanks.
Take care.
Bye-bye.
Yeah. Bye-bye.